All right. Good afternoon. Can everybody hear me? I get a thumbs up from anybody. Okay, good. Great. Thank you so much. I'm Commander Dubill. I am here at Naval Medical Center, Portsmouth. And behind me, I've got Commander Snyder and Lieutenant Commander Whittington. And we're here to share with you our experiences with OAR. I just wanted you to see us all first before we share our screen. I'll take my mask off for a second so you can hear me okay. And then we're going to just share our experiences at our 3 different sites. I was at Sigonella, Dr. Snyder was at Rota, and Dr. Whittington was at Fort Pickett, and we've all returned home safely. We have 2 other providers who are still stateside but deployed. And I'm sure they'll be sharing their experiences when they get back. So let me screen share. I'm going to need your help here.
Screen share is actually right here. And then you hit this. And then you go to Windows and that. And share.
And then pull it up.
This. And then
you got it. Okay. All right. Perfect. That's all of us. And then I can't see questions as they come in if I am screen sharing, so just save those and we'll go over those at the end. Sigonella, just a little bit background. I received 48 hours notice to deploy to NMRTC Sigonella. I was told we would be providing care for our travelers and our civs. I was told to pack some bedding. And that was about it. I am a GYN oncologist by trade. There were 2 OBGYNs there. You want to take that for a second? There were 2 OBGYNs already stationed there. So I took a quick second to call them and see what we were walking into. The message I got.
Shoot. Hold on 1 second.
Oh, yeah.
It's showing Outlook. So
okay.
Pause this.
Stop sharing. Thank you. Sorry about that, guys. And show.
Oh, we have to draw a red box. So close this.
Mm-hmm.
And then go back to the this one here.
Yep.
All right, now go here again.
Mm-hmm.
And then hit the desktop window.
Mm-hmm.
And then if we do the entire screen, Bridget, will it allow me to then see there we go.
How's that? Is that better?
Can you see it now?
Sorry, guys. I'm a better surgeon than I am IT.
Okay, so full screen. I'm not sure how to do that.
Hey, this is Kevin Schofer. We can see your slides. I think if you guys just do the presenter.
So
hold on, I can't hear both him and you. What was that, sir?
We can see your slides. I think if you guys just hit presenter, you'll be good to go.
It is presenter for us. Let me end it and try it again.
So go back to this, I think. And what's the top left-hand button? Oh, so just go up to the PowerPoint again.
Mm-hmm.
And go, hit the beginning, from beginning. Are you, because that's what we just did. And what do you see now?
Sir, can you see it now?
Yeah, well, it looks, I mean, honestly, if you just toggle to the second slide.
Yeah.
You're still on the first slide from what we can see here, from what I can see.
So yeah, I'm sorry. It says that we're sharing and I see myself in a presenter mode.
Okay, so end that show. Can we go back and
I'm going to stop sharing for a second.
It went to the second slide then, so maybe it was just.
Oh, it did? So there's just a delay then, it looks like.
Yeah, I think it's just a little bit of a delay.
All right, let me go back to that then.
That's got to be our internet.
And then
we did Chrome tab is what we did.
I wouldn't do it because then you can't get your PowerPoint. Okay.
Okay.
So let me share that again. I'm going to go to from beginning. I'm going to toggle and then let me know when it gets to that second slide and I'll just talk about it a little bit. It's just a bunch of numbers. So again, short notice to deploy, not a lot of information. When I called the OBGYNs downstream, they said that there were about 50% of everybody who was getting off the planes were pregnant. So I ran to labor and delivery, delivered some more babies again so I could remember how to do that. Grabbed my old pregnancy wheel, packed up, and I had orders about 2 hours before I had to hit the airport, and everything went really well from that point. At Sigonella, once the second slide comes up for you guys, we were there to provide the medical and dental triage and treatment to about 4,000 Afghan travelers, legal permanent residents, and UK, Canadian, German, and US citizens transitioning from Afghanistan. We had both emergency care, infectious disease, primary care, and acute care. There were 183 personnel on site from Sigonella that participated, and 90 augmentees from 12 worldwide commands when we showed up. We had resuscitation and Rule 2 surgical capabilities to support 51 inbound and outbound flights over the course of 2 weeks. Did that second slide come through?
No, I'm still seeing the title slide, just so you know.
How about now?
No, not here yet. Like I said, there might be a little bit of a time delay.
Okay. I'm just wondering how quickly to toggle through.
It's still on the title slide, so.
Let's see. Because we have fun pictures, right? What's a brief without fun pictures? I don't want to just talk about the things we did. Let's see.
What if you share the entire
screen? Let me close everything real briefly. And then try this. I got to close all your stuff, okay?
Yeah, close all that.
I'm going to close all your things. Not that one.
Yeah.
And then,
yeah. And then entire screen.
Okay.
Share.
All right. Do you guys see a second screen now?
Now you're good, I think. Yeah,
Good.
we see the second slide. US
Perfect.
NMRTC Sigonella.
Love it. All right. So those are all just the numbers I told you. We saw a lot of people in 2 weeks, right? We had a lot of inbound and outbound flights in Sigonella, which was amazing. The numbers I got from our site, we executed 2,000 medical and dental patient encounters, 4,000 COVID tests. We were COVID testing 100% when I showed up. 300 vaccinations given. We had 39 OBGYN patients, and since that's what I do, I just wanted to touch on the fact that those were the 39 that showed up for medical reasons. There were way more pregnant patients in the population, but we were primary care only and getting them off our site to their next site. So we weren't actively seeking a database of these pregnant patients. There were 2 medevacs for 37 travelers. One was a pediatric patient who was quite ill, came to Portsmouth Naval Hospital, and the remainder were high-risk pregnant patients who went to Walter Reed. And then there were 12 surgical patients that were taken care of there. So the slide that you see on the larger picture, that is our flight line, where the flights were received. I had the privilege of watching 2 of these flights come in after hours. People are exhausted getting off the flight. It was quite organized. There were lines. Of course, there was security and dogs there. There was an amnesty box, which was new to me. Put anything in there, drugs, weapons, and then they filtered into being processed. And there was a small medical, you can see it underneath the flag past that. That was a small medical footprint there for emergencies at that point. And then our travelers were sent to one of 5 sites. We had this flight line. We had actually 4. We had a hangar bay, and you'll see a picture of that in a second. We had barracks that were converted to house our folks. One of the depots and the gym were the main sites. And there was a medical footprint in every one of these places that was 24/7. Additionally, we had a flight line clinic that was 24/7, where if you needed something that couldn't be done in a tent, we could potentially do it there. And then on Sigonella, the hospital was not on the same base that all this was happening. The hospital was about 10 minutes, 15 minutes away by ambulance. And so we did not have hospital capabilities where we were. This next slide, you'll see the larger picture is the hangar bay. So you can see how people were living while they were on site, and you can see how quickly infectious diseases can spread in this facility. During the daytime, the one door was wide open. And so all sorts of insects could get in at night. It was also open. Lights were off though. And then the site where I spent most of my time, you'll see the other two pictures, they were housing units that were converted really to hold some of this population. And so when we needed isolation for a particular place, families were shifted in between these. And they had free reign. And then medical, we were really close to this area and separated really only by a chain link fence at this facility. This is where I worked primarily as an implant OBGYN. We were running 12-hour shifts. Anytime there was an obstetric patient that needed care, I or one of the other OBGYNs ran to whatever site that was, or there was a golf cart if we were able to use that, or a gator to get where we needed to be. And so we were at all places. And then when I was not taking care of obstetric patients, I was doing primary care. We were told, this is my one funny story that I'll tell you, when we were welcomed aboard, to operate at the top of our credentials, right? To see patients at the top of what we could do. And then the medical director said, well, except unless you're a gynonc, which I am a gynonc. So everybody had a good laugh about that because they didn't know that I was in the crowd at all. So I operated as a primary care anytime that I wasn't seeing obstetric patients. And it was really interesting. It was great for me. That blue tent you see over there is our check-in desk and our patient waiting room. And then there are two larger tents behind it. This was the Charlie station, which was by far the busiest. And that is where I housed myself when I wasn't running between the other places. And you can see the inside of both. One was primarily a dental or procedure area, and the dentists were incredibly busy every single day at this place. And then the other side, that's half of a tent. So we had about 4 stretchers on each side for privacy, for female exams. There were blankets hung in between. So we were able to sort of post a corpsman or a nurse on one side, zip the tent close on the other, and do exams of the abdomen. That was the most sensitive exam that I did. And that was still a little bit difficult with some of the needs of the culture. And so that's where we saw patients. And that was my pharmacy, my very last slide there. That's the pharmacy, which was amazing. They had almost everything we needed. We used a book to figure out what the dosing was, right? Very old school for me. I was taken back to my medical school and intern days, and kept a log of everything that we handed out. So some things I just decided to call us medical school refreshers because I had to relearn a lot of things. Oral rehydration solution. This was what I gave out the most. And we made this ourselves. And you can see on the top picture how we did this, right? We measured this out, and that went in a 2-liter bottle of water. And, if it was a child, we would measure out essentially how much to give the child based on their weight every time they had an episode of diarrhea. Malaria, this was actually our biggest thing. There was measles towards the end, which I wasn't involved with, but malaria was there from the get-go. There was a rapid malaria test. People were quite sick. And unfortunately, this is endemic to Sigonella. I think the last outbreak was in the 1950s. It has been eradicated, but the mosquitoes that can pass it are in Sigonella still, and you saw that Hanger Bay, right? So these are people we isolated quickly and treated. Chickenpox, I saw my first day there actually. Leishmaniasis, wow, I really had to dig back to medical school on that one. Cerebral palsy, I saw a lot more children with cerebral palsy, not personally, but 1 or 2, but out and about, and my colleagues while we were there, than I thought we would. And then I'll let the 2 other ladies talk before we talk about social and cultural barriers and trauma. This was the hardest for me. I don't know that I was really prepared for this. Before I forget the 2 pictures, on the bottom, we didn't have IV poles, right? So I tied up my stethoscope to hang an IV. And then in that folder, you'll see every one of those papers is a patient encounter. And every one of those slots is a day, just to give you an idea of how busy we are. Sometimes we only had 2 providers on site. Sometimes we had 4. We noticed a big flux in the morning after breakfast, and then we were busy all the way up to about 11 p.m. and then a trickle throughout the night. You know, I don't know that I was quite prepared to see some of the things that I saw and hear some of the stories that I heard. There were people with physical trauma, people who were trampled trying to get away, people who were thrown over fences, trying to get onto the planes. There was a lot more emotional trauma than there was physical. It was a little bit tough to sleep, probably for my first week there, just because my brain kept chugging, had a hard time just really grasping everything that I was seeing on a day-to-day basis. You know, some women were, you know, had 10 babies. Just one woman I remember seeing with a translator. We needed a translator for most everybody. Came in with chest pain, and I remember the translator telling me gently, "Well, doctor, maybe she has chest pain because she has 10 babies, and the other wife has 5, and she's watching them all." You know, just things that I wouldn't think about or think to ask. You know, I got an EKG anyway, but little things like that, right? And so I'll let the other 2 chime in before maybe we take some questions on that. But that was a big takeaway for me. You know, I'll go to this next slide. That was most of the team I worked with in the Charlie tent in the large photo, and then you know, us at the pharmacy, you know, hanging out talking about patients, and then our medevac of our pregnant patients off. This was a great refresher for me professionally and personally. This was the Navy that I remember from my academy days, where everybody showed up excited, everybody showed up ready to help, everybody helped each other, and everybody did the work that needed to be done. And even though it was exhausting and a little bit difficult to quiet your mind at night, it was wonderful. It really was. I made some wonderful friends. I learned a lot from, you know, the doctors and nurses and corpsmen I worked with. Hopefully they learned something from me too, and I will take away a lot of great memories from my very short 2-week, I called it tentcation, since we were in these beautiful tents here. And so I'm going to turn it over to the other 2 briefly, and again, we'll take some questions towards the end.
So good afternoon. I'm Commander Snyder, and I was the one who was sent to Rota. So first of all, thank you very much for your patience in the beginning. I apologize for the technical difficulties, but glad to see that we are up and rolling now. So much like Commander Dubell, I was given also a 48-hour notice. Actually, when the taskers kept coming through, I approached Commander Dubell. I was slated to separate from the military on the 31st of October. And I reached out and I said, I need to be part of this. So I extended my time in the military just so that I could take part, and was very thankful that my extension was approved and routed literally within a matter of hours. And then within 48 hours, I was on a flight to Rota, Spain, really to participate in something quite amazing. So I'll give you a little bit of background about what we did out in Rota, and then I'll share some of my experiences as well. So we had the successful provision of approximately 2,400 OAR personnel. You know, we sustained both medical and dental triage, and then sustained medical care for all of the personnel. We had a total of 21 active duty personnel from 11 different Navy commands. And while we were there, we maintained 24 hours, 7 day a week medical operations across 3 different sites. We had the flight line, the base, and then of course the air terminal aid station, which we commonly refer to as the BAS or the battalion aid station. That also supplemented the MTF capabilities. While we were there, we executed over 2,000 medical encounters. We were also initially providing COVID tests to over 2,500 personnel. We had 116 dental procedures that were performed. This included extractions, INDs. We provided over 1,300 vaccines. That included the MMR, varicella, polio, and then COVID vaccines. We had a total of 48 OBGYN patients, never felt more relevant as an OBGYN in the Navy. Delivered one baby. We evacuated 5 evacuees were actually transferred to the facility. 4 of them were admitted, and one of them was actually transferred out to the host nation network. And we performed 1 orthopedic surgical procedure. So just a little bit of background about what my main role was during my 30-day stay in Rota. It was actually a little bit different than Commander DeVille. I know that each one of us sort of fulfilled various roles when we got to our locations. I do feel that I was utilized mostly as an OBGYN. So I, was not asked to do primary care. Of course, I was out at the battalion aid station providing care, but it was mainly for the obstetric patients. So I really did stay within my scope of practice and feel that I was able to perform at the top of my credentials. But when I first got there, I had no idea what to expect. I like Commander DeVille, was told to bring sleeping, be prepared to sleep in tents on cots. So I really didn't know. So when we got there, we got checked in, and we then were out on the flight line within 3 hours later. The flights were coming in at various hours in the middle of the night. And my main role was to basically be out at the flight line for all the incoming flights, and to provide initial triage for the evacuees as they were coming off the flights and as they were processing through the hangar. So you can see our team. We literally walked out to the flight line every time a flight came in. The picture here is with our orthopedic surgeon and our general surgeon. So we were the IA surgeons here on the left. And we did an initial triage for the patients as they, not the patients, but the evacuees as they were coming off the flights. When they walked through the hangar, they were seated, and we were charged with doing basically a triage of every single person to see who may need medical attention. Oftentimes utilizing other evacuees as the translator. We did have several translators that were available to us. And then we would identify immediate medical needs and then provided them with the immediate care that they actually needed. Once they actually got processed, as you can see, this was various pictures out on the flight line. That woman you see there in the wheelchair was one of the pregnant patients who came off the flight line, term pregnancy. They told me she was actually post-term and that she was contracting. This was my, sort of first experience with taking care of a pregnant patient directly off the flight line, which was later, she was brought over to the hospital, evaluated, and found to be fine, not in labor. But as you can see, these were the things that we had no idea what we were going to encounter as they were actually coming off the flights here. This picture here with where I'm holding the baby, just a little story. That baby was 2 days old, and the woman who delivered that baby had a C-section. And so when she got off that flight line, she had a really bad headache. Of course, my initial concern was that she had preeclampsia, just given her, some of the fact that she'd had so many babies and the headache. So my worry for her was that she could be very sick. Eventually, she allowed me to evaluate her because all she was asking for was a Tylenol. And I did evaluate her, and she did have a blood pressure of 180 over 100. So she was sick. So moving on, you know, these are pictures of once we, you know, got everybody sort of processed through, and they were staying in the tents. You know, there were so many volunteers that came together and provided toys for the children. You know, these children had been through quite a bit, and we wanted to do everything we could for the children. I know the community really came together to sort of donate and provide as much as they could. But we joked around that all these bikes were going to create orthopedic injuries. Thankfully, nobody got seriously injured on those bikes, though. So I'll go back. Really, this is as far as the remainder of my experience. I, again, spent time out at the battalion aid station caring mostly for our pregnant patients. And once we evacuated a majority of the evacuees and they transferred out of Rota, we had a remaining approximately 500 refugees that were basically halted. And I believe it was due to the measles outbreak. So while they were there, the decision was made to vaccinate them. And you know, we decided that we had to take pregnancy tests because, you know, you cannot give MMRs, varicella, you can't do the live vaccines for your pregnant patients. So for every reproductive age female, we had to obtain a point of care pregnancy test. So we ended up discovering 12 new pregnancies for patients that had no idea that they were actually pregnant. And then some of them knew that they were pregnant, but then didn't share the information. Many of those pregnant patients had no idea how far along they were. Most of them thought that they were actually further along than what they actually were. A lot of women told us that they were beyond due, which of course, you know, for us was, we wanted to know who was close to being, you know, close to delivery. So we ended up doing an ultrasound clinic so that we could actually date all these patients and have an idea of exactly when these patients were due. That decision was made after we ended up having the patient deliver. She did get to the hospital barely in time. You know, we had golf carts that we were able to, if we really needed to have the ambulance, we could, but we tried to use those for true emergencies. And I will tell you that the Afghan female population, when they're in labor, they really do not make a lot of noise. So you really don't know how if they're truly in active labor or not. And we got her to the hospital, and within minutes she ended up delivering. So didn't make a peep, didn't make a sound. And you know, we were just thankful that we actually had her deliver in the hospital. But you know, this was why we felt that we needed to do that ultrasound for everybody just to see how far along they were. So I found myself doing ultrasounds in a tent on cots where I was basically kneeling on the ground and using the little portable ultrasounds. So definitely a different experience than what I've ever been used to. And, you know, much like Commander DeVille, some of the stories from the patients that I had talked to, you know, were incredible. One lady was concerned because she hadn't felt her baby move since she fell off the wall trying to escape the Taliban. So when she got to us, she was contracting and she hadn't felt her baby move and had this history of trauma. So thankfully she was fine, and so was the baby. But you know, these were, you know, some of the situations that we didn't know, you know, what to be prepared for until they actually until it presented itself. And so we'll save more for questions, but now I'm going to turn it over to Lieutenant Commander Whittington so she can talk about her experience and give her story.
All right, good afternoon, everyone. Thanks for joining us. So
So I went to Fort Pickett, which is about 2.5 hours away from Naval Medical Center, Portsmouth. Fort Pickett is a very sparsely populated base that is used really as a training center for some Marine units, some SEALs, and Army personnel prior to deployment. So there's not a lot of resources at Fort Pickett. There was not a hospital. Within about 45 minutes was the closest one. There was a troop medical clinic, which had a capacity for 5 or 6 personnel to be seen. So when we got there, it was amazing how the resources that we had to work with. So we arrived on the 27th of August. And essentially, there was a lot of equipment there. We had 2 metal buildings, which I'll show you shortly. And we were told that we were not necessarily going to be doing direct medical care or primary care or emergency care, but our goal was going to be to provide medical immigration screening and also to just vaccinate as many of our evacuees as possible. There were 85 personnel that came from NMRTC Portsmouth. And when we arrived, the U.S. Army Airborne 101st was there already, and they had started to prepare things somewhat for us. So if you look at the bottom picture, those are the 2 metal buildings that we used basically to set up our screening areas. We were basically trying to get it together as quickly as possible. Medical screening for immigrants or evacuees is essentially making sure they don't have any major communicable diseases, any significant medical history that would need them to be seen sooner, and then just providing vaccines. So we get there the 27th, the 28th, our first arrivals come. Well, we were told we weren't necessarily going to be doing medical care. There were some contractors that were going to be doing the actual care. The problem was there was a couple of PAs that were there establishing their clinics, and they weren't quite ready to take care of the large influx of evacuees that we got just on that first day. So for about 3 days, I did function as an obstetrician. Anytime there was an obstetric emergency, I would go and evaluate the patient and ultimately decide whether we would need to deliver there or put the patient on an ambulance and get them to the hospital that was 45 minutes away. So those 3 days were a lot of fun. I was on call basically 24/7. And in the picture here, you can't really appreciate it, but our barracks were probably half a mile from our medical site. So it was quite a ways. Lots of running. It was really good for preparing for our PRT. If you look up at the right-hand side, we tried our best to just make sure that the evacuees knew how grateful we were for their assistance over in Afghanistan, and that we were excited to see them and excited to help them as they go through their relocation process. So all of our signs, of course, were in multiple, both Dari and Pashto, that were kind of trying to help them navigate the base. So we get there the 28th of August, and our mission starts on the 1st. We need to screen all these people. So we sent a team up to Fort Lee, who was already operating in this capacity, and looked at their model and how they were seeing the number of patients they were seeing a day. Basically, they had multiple rooms that allowed for patient privacy, which is, of course, exceedingly important in their culture. So we didn't have that. These were basically large open buildings that had really no partitions. And so we had to figure out how we were going to provide privacy when we did our screening medical exams, and how were we going to get through the large number of patients that we needed to see. So one of our personnel that went with us came up with the idea that, much like we do in some of our clinics here, that we would have a medical home. And instead of the family moving from room to room, from lab draw to immunizations to exams, that we would keep them in one place, and we called that a pod. And so we would have a team of physicians, a team of corpsmen and nurses that would just treat, 1 or 2 families at a time. They were very successful with this. We basically went from seeing 113 patients the first day to 226 patients by the 4th day. our daily output would ebb and flow based on changing missions, which I'll talk about. But there was one day we got up to like 280 patients in a day, which going through their complete medical histories, giving vaccines, all of that, it made for some really long days, but we were really excited to be helping that many people. So if you look at the first kind of top middle picture, we didn't have many proper partitions. So that is a shower curtain and paracord that we use to make areas of privacy for our female evacuees. If you look over to the right side, you can see some of our corpsmen. I'm doing some paperwork. And then there is a gentleman next to me who is one of the contractors, because not only were they doing medical care, but eventually they were going to take over the medical screening process also. So part of our mission was also to train them and how to do the medical screening. Looking down below in the below middle picture, that was one of our family medicine doctors basically giving a brief on how to optimize our throughput and get more patients seen so that ultimately they could move on and work on getting their relocation completed. So medical was one of the steps that really could keep people there at Fort Pickett. And then just over to the bottom right, that's an idea of all the how we gave vaccines. So each patient would have a slip of paper with their name on it and whatever vaccines were ordered. And then we put all the vaccines in a kidney basin for each person, and then we would take them to the person, whether they were in a chair or on one of the exam tables. Basically anywhere that we could vaccinate and the patient be comfortable is where we would vaccinate them. Commander Dubell and Commander Snyder have already alluded to this, but some of these families had 14 people. And so trying to complete the paperwork and the screening and the vaccines could take a significant amount of time. So I talked about shifting missions. So on the left is a photo of what the barracks looked like there. So our evacuees were staying in barracks like that. And if you look to the right, this was basically how close the beds were together. We did a lot to keep the windows open and the doors open to promote ventilation. But our evacuees were in very close contact. There were 4 dining facilities that they could go to, but between the way they lived in barracks and then the number of people that would be going through the dining facilities, when we had an isolated case of measles, our mission shifted. And it was away from just being medical screening to how can we vaccinate as many people as possible to minimize the spread of this. So the only people we didn't vaccinate were less than 6 months old. So typically we give MMR over a year, but in high risk populations, you can give it at 6 months. And then if they were pregnant, we couldn't give it to them either. Although there was a discussion at one point, when you have a low resource area, sometimes MMR is given to pregnant women just because the risk of spread is so great. And there hasn't been documented transmission in pregnant women of rubella to their infants, although it has been found in cord blood. So we talked about that, but then we decided we were not a low resource setting and that we could figure out a way to not give pregnant women MMR. So the goal for the people that you can't vaccinate is to prevent the severe sequelae of the disease. And so in pregnant women, we would screen them for seropositivity, and about 90% of pregnant women were immune to measles. And so we didn't need to give them immunoprophylaxis. Whereas there were 19 women that were non-immune, and so they were taken to an outside hospital and given IVIG. Now, the babies that we couldn't vaccinate, we did have IMIG available, and so we would give that to them along with their vaccinations. So we worked really hard, as all people do, much like our colleagues here that went overseas. The stories of trauma were a lot to hear about and handle, but there was also a lot of joy and a lot of gratitude because by the time they had gotten to Fort Pickett, they had made it to the US. And so there was a lot of fun that was had.
We had toys, we had candy, we had coloring contests. One of our corpsmen said that we were at critical mass for fun at one point. So it really was a great time. And ultimately, in the time that I was there for 30 days until I needed to be pulled back to Portsmouth. We got 4,800 medical screenings done, which is pretty amazing. Right now, Fort Pickett has over 10,000 evacuees, and every day they're still doing the same thing. They're getting the medical screenings done and trying to help these people get resettled here. So a little bit of a different mission at Fort Pickett, but again, very rewarding. So that'll conclude our PowerPoint, and we will open it up for some questions.
Sure. All right. I'm going to stop that. And show. Okay. All right. Floor is open. Who has questions? Or you can type them into the box. I can see that now. Or just speak up. Nothing? I see Lieutenant Commander Tim Brooks on there, who probably has a lot to say about Sigonella. I don't know if you want to chime in.
Well, we've found ourselves in another emergency event currently, so I was a little late getting in. We're dealing with our Mediterranean hurricane, so I'm sorry I missed the brief on
I hope
this.
you're doing well. I hope you and your family are doing well.
Yeah, but no, I'm excited to hear about all this. I've been paying attention to all the good work that's happening in CONUS. So, but no, we were so glad to have Commander DeBille out here and helping us, and as well as everyone else who joined us. So I got nothing else to add.
Oh, well, thank you for your hospitality, sir. It was a great experience. Let's see, any significant disease presentations meaning more advanced than what you have previously seen stateside? You know, for myself, no, you know, I know the child that was medevaced that Captain Epperly had taken care of, who we previously thought was a cerebral palsy child, got RSV and decompensated quite quickly, you know, and he rightly was suspicious that that was not cerebral palsy. And it was a presentation of, I want to say it was muscular dystrophy, one of the dystrophies that Captain Plime took care of once we received stateside here. I did see some really weird stuff. I think the sickest patient I took care of was a septic patient, postpartum as well. And Dr. Travis whisked her away to the hospital and turned her right around pretty quickly. One of the weird things, one woman came, I forget, she was less than a week, no, maybe a week postpartum, and she said, could you look at my C-section via translator? And I said, well, yeah, sure, I can do that. And then she had these long sutures, they were permanent sutures, hanging out of her skin so much you could walk the dog with it, I like to say. And I thought to myself, well, I don't know what to do with this. I think these are permanent sutures, and I think I should cut them out, but I don't know how to do that. And they had grown in at that point, so, you know, I start to undo, kind of get the knots away from the skin, and I look at her and she's not wincing. As Commander Snyder alluded to it, I asked her, I'm like, do you want any medicine? She's like, oh, no, just go to town. And so I'm getting these knots out of her skin and cut them and pull them. And I, to date, haven't found anything online and I wish I would have asked her if we could take a picture of that. But that like put me out of my comfort zone. And then concurrently, she said, well, could you check out my baby? And that baby was actually kind of sick. I said, please get some vitals to one of my corpsmen who got vitals and give it to me. And I'm like, well, I have to now look up if that's normal or not. And it was not, right? And our pediatrician was busy taking care of that sick child I just spoke to about. And so I ended up waking a pediatrician here up at Portsmouth up at 4 a.m. and said, sir, I need your help. Can you take a peek at this? is this a viral xanthan on this newborn, or is this something else? And he remotely diagnosed that child and gave us the right treatment. And that kiddo did okay as well. And then the same patient actually couldn't breastfeed, didn't have a latch, and we had an L&D nurse there and a postpartum nurse, and man, they were on it. They were helping this woman cross-culture, no translator, trying to figure out how to feed her baby, and that was quite amazing. Did you see anything else more progressed than you would expect?
I mean, we had a lot of, nausea, vomiting, diarrhea. I mean, that was, like you said, a lot of the oral rehydration. Some of it was when I say self-induced, we, had an outbreak with our food poisoning once. So, that was kind of several people were coming up to the tent with nausea and vomiting. But nothing, again, like you, there were a lot of the children that I saw that had cerebral palsy. One guy was carrying his son over his shoulder because the Taliban wouldn't let them take the wheelchair. So, Rota being a very small community, there is a very large presence of, just the families there, MWR, Red Cross. They put a message out to one of the wives. And the next thing you know, we had 3 walking strollers that were donated. So we were actually able to provide this family with a running stroller. And he'd literally been carrying him around over his shoulder the entire time. Got off the flight that way. His little brother would also carry him because, he was non-ambulatory. So, we saw quite a bit, and, little girl with, just crutches, and it just a lot of different things that we wouldn't necessarily see in the United States.
Yeah, I agree with Commander DeVille's slide earlier when she talked about seeing things she hadn't seen. I had a family that probably 3 out of the 12 of them had pretty diffuse leishmaniasis, which when you first look at it can be quite disconcerting with how large the lesions can be and how uncomfortable it looks for them. But we were able to get that diagnosed and get treated. I agree 100%. There is a lot of cerebral palsy and a lot that did not have wheelchairs. And so very much families basically switching out who was going to carry the non-ambulatory kiddos. We did have some interesting patients that I think probably had some genetic syndromes that had gone undiagnosed. So, a constellation of a heart defect and a cleft lip or palate. And the parents say, oh, yeah, those were just things they were born with, but then definitely had some interesting faces to go with it. And trying to get them to understand, like, this needs follow-up with specialists and surgery and things like that. So just some interesting things that we saw that you might see in the US but would already be diagnosed.
Yeah, that jogs a memory of a patient who was coming in for some progesterone shots. And I think I actually called Dr. Whittington quite a bit because I'm, again, gynonc, I'm doing my best. And I asked why, and through the translator and really breaking it down, she was married to her cousin and her sister was married to his brother. And that couple had children with hydrocephalus. And somebody had told her the progesterone would prevent it and given her a supply to take with her. And so, yeah, there were some things that just don't come up in other places. I think if there are no more questions, the one thing that I would really just like to say, and I think all 3 of us feel the same way. I mean, you heard Commander Snyder. I cannot thank her enough for stepping up and extending her separation to fill in that gap. It is hard to pick up that phone to that family member and say, hey, I'm going to step outside my comfort zone and I'm going to leave you. And I don't know how long I'm going to leave you for. And I'm going to leave you real quick. But I don't think any of us regret it. That was easily one of the best things that I've done in my career. And so when those phone calls come or those emails come or your department head or specialty leader saying, I need somebody, I would encourage you all to please raise your hand and say, yeah, I'm going to do that because it is well worth it. And that's all I've got. All right. Thank you, everybody. Thanks.